Hello, dear colleagues and friends. I am Marco Eusanio. I'm Chief of Cardiac Surgery Department at Lancisi Cardiovascular Center, University of Marche Ancona. I'm very glad to open and contribute to this digital symposium from Medtronic within EACTS, which will make a focus on new evolving indications and interventions for patients with aortic stenosis. So with indication to TAVR expanding to always lower risk patients, I think the role of the heart team gains importance to assess the weight of clinical and anatomical patients' characteristics and eventually define what is the most appropriate intervention in a single patient. So objective of this session will be basically to review new data available on TAVI for low risk and bicuspid patients, to discuss the implication of these new data, both for TAVI and SAVR, and explain the minimally invasive SAVR approaches and why and how they can advantage surgical practice. So I'm very honored to contribute to this symposium together with two experts in the field, Professor Sabine Bleiziffer from Modine, Germany, and Professor Thomas Modine from Bordeaux, France. The agenda will contemplate three presentations, one from each of us. I will have a presentation on minimally invasive AVR in 2020 and beyond. Professor Sabine Bleiziffer will talk about expanding options for bicuspid aortic stenosis patients, TAVR and SAVR, while Thomas Modine will address the right choice for low-risk aortic stenosis patient. We will have appropriate time for discussion between the presentation and at the end of the presentation, just before closing. So, dear viewers, I hope you will enjoy this session, and I will start with my first presentation, which is about mini AVR in 2020 and beyond. So, this is my hospital in Ancona, and since I moved there about 4 years ago, we've been working hard to achieve basically two goals. The first one is to make minimally invasive standard of care, and the second one is that having surgeons should be able to cover all minimally invasive and catheter-based approaches. So, according to that, in a period that saw our volume patients volume increasing up to 1,250 cases, you see also the effect of COVID. We will be losing about 250 cases by the end of this year. In 2019, we could perform about 90% of all aortic valve minimally invasive and about 2/3 of the mitral valve with the minimally invasive approach. And also we started a TAVI program in cardiac surgery. So as the surgeons, independent from the cardiologists, we are doing TAVI and we are able to offer all possible options to patients with aortic stenosis. But why am I talking about TAVR? Because the fact that surgeons are doing TAVR is extremely important for them and for their surgical, especially minimally invasive program. In fact, that allows to perform TAVI for surgeons means to maintain patients' referral. I think this is very important. It helps us to remain balanced in SAVR versus TAVR decision making, and also we can acquire new skills and likely develop a truly hybrid intervention. This is an example. This is a patient requiring a minimally invasive mitral and tricuspid valve repair. He had a severely calcified aorta. We would have turned him down from surgery, but we, transferring percutaneous technologies into our surgical practice, and in particular by using a neuroprotection catheter-based systems, we could operate successfully in this patient. This is what we're doing in this moment. So I think that to put together catheter-based and open surgical techniques allow us to improve our clinical results and expand our indication. And this was the transaxillary mini thoracotomy that we always use to repair mitral valve and tricuspid valve. And these are 8 of the CT scan of 8 out of the 10 patients we'll be treating with this hybrid approach. But I think that as a surgeons, we learn a lot from TAVR. TAVR, this is one understanding. This is probably very easy, it's under everyone's eyes. TAVR is the least invasive aortic valve intervention. In fact, it does not require incision, no anesthesia, no pump, and it allows immediate recovery. We all know this. But what is the lesson for minimal invasive AVR? We can reduce incision, of course, but we can also make minimal invasive anesthesia. We can make minimal invasive extracorporeal circulation and put energies and efforts, invest resources in an early rehabilitation program to have immediate recovery. The second understanding, to me, was to understand why TAVR is a game changer. There are many reasons that make TAVR a game changer. Probably one of them is that TAVR is simple, it's easy, it's reproducible, it's an operation that all operators, even cardiac surgeons, love doing and love learning. So I think if the concern here is to disseminate minimal invasive valve surgery, I think we should put energies to develop minimal invasive techniques that are easy, reproducible, simple, and to me, this means direct vision. The third understanding was this one. TAVR has revolutionized the standard measures for the evaluation of an interventional procedure. Now that we have TAVR, patients are strongly requesting operation associated with less trauma, with immediate recovery, with an almost untouched quality of life. This is a very strong request we get from our patient. And the lesson here would be, of course, we should continue to generate excellent short and long-term outcomes, but at the same time, we should get concerned on patient satisfaction, on perioperative quality of life, and improve that substantially. After all, quality is as important as quantity of life to our patients. And we understand that when we look at the increasing trends in the use of biological valve in the young patients. They don't want coumadin because they want a good quality of life. We understand that when we see patients asking, although they're very young, TAVR instead of SAVR, because the certainty of a fast recovery is apparently more important than the certainty of a durable valve implanted in their heart. And they learn this looking at other specialties, orthopedics, thoracic surgeons, spine surgeons, they're all doing minimal invasive. So they want the same from us, from cardiac surgery. And you see that catheter-based intervention to treat heart operation are increasingly offered. So I think that as surgeons, we should go minimally invasive. And are we ready to target this quality of outcomes, this quality of life outcomes? Absolutely. This is our experience. This is a 3-year experience on isolated surgical AVR, 624, all comers, low-risk patients. 30-day mortality was 0.3%. 30-day stroke rate was 0.5%. So I think that when we approach 0% in terms of mortality and stroke at 30 days, we enter in that condition of excellence that secondary clinical endpoints like reduced incision, cosmesis, pain, fast recovery, atrial fibrillation, blood transfusion gain importance and become, and should become, according to me, new measure clinical endpoints in cardiac surgery. When we have mortality of 0.something%, these measures of outcomes that are going under the umbrella of patients and family satisfaction, they really make the difference. So as surgeons, if we learn to improve our outcomes in terms of patient satisfaction, we will have done a very big step forward, I think. So I think we have, our patients are strongly asking for minimal invasive procedure. We should better listen and respond to them if we want to remain key players in the management of these patients, if we want to remain their interlocutors, if we want to remain able of engaging them. And full sternotomy is not a good response. Continuing to offering full sternotomy when it's avoidable, when it's possible to avoid it, I think it's like being in the market trying to, to promote an item that nobody wants, nobody likes. It doesn't really matter how much we think is nice, effective, safe, fast, whatever. They just don't want it. So I think it's useless to continue to offer this kind of approach when it's possible to avoid it. And also we will make happier our administrators. I will not take the very last paper on cost effectiveness of minimal invasive cardiac surgery. I will take one of the first one we know from 1997. The title here is very sharp and clear. Minimal invasive cardiac valve surgery improve improves patient satisfaction while reducing cost. So I think this is made quite clear. And how do we interpret mini AVR at Lancisi Hospital? This is 2019. We've done about 470 aortic valves. If we cut off the combined aortic valve replacement that were done through a full sternotomy, we see that only 24 were done minimally invasive. And these were the endocarditis and the heart reduced. All other were done minimally invasive or transfemoral, TAVI. And why are we doing? Recalling lesson number 1 from TAVI, we, as a surgeons, we are reducing incisions, of course, but we're trying to transform this minimal invasive technique in a minimal invasive therapy involving our perfusionists and using minimal invasive extracorporeal circulation as much as possible. Asking our anesthesiologists to apply ultra-fast track anesthetic protocols in order to have immediate rehabilitation programs, in order to have immediate patient-family contact and decrease the burden of surgery. We call this a 360 degrees minimal invasive cardiac surgeon. Our incision, we have all of them. We're using mini sternotomy, right anterior mini thoracotomy. We're doing the transaxillary as well, and type of incision will be selected based on patient clinical and anatomical characteristic. This is mini AVR. Usually at the fourth, we do a very small skin incision. We call this 2-finger surgery, and we're doing also the David, the Bentel, the ascending aorta, the aneurysm surgery, I would say. Mini thoracotomy. This is our approach, and the lesson number 2 was to make it simple. So we're not working in a narrow intercostal space. We're not cutting the cartilage, but we're cutting the sternum like this. So we make a wedged incision at the level of the rib that allow us to displace the same rib to caudal in order to have a larger operative field and have a perfect visualization of the aortic valve like this. And this is a very short clip. You know, the groin has been cannulated here. We're doing a 4 to 6 centimeter skin incision. This is the thoracotomy. Displacing the rib to caudal. So surgery must remain simple. If you really want to disseminate these kind of approaches, it should not remain an operation that are done by few surgeons. These are stay stitches for the pericardium that allow us to have the valve in appropriate position. We're clamping the aorta. We give cardioplegia. The aorta is open here. We're resecting the aortic valve. And this is an avulus that is implanted. You see how good is the visualization of the annulus. Surgery remains simple. I'm not sure that is making any difference for the patient to have that minimal rib detachment. Surgery is natural, is easy, can be performed by the younger patient, by the younger surgeon, and this is the result. And this is the transaxillary mini thoracotomy that we've done in a few cases. We take this from our experience with mini mitral surgery. This is an approach that allows us to be very perpendicular to the valve and have a direct vision surgery, very intuitive. You know, we get very perpendicular to the mitral valve, so we can operate as every day through a sternotomy. We don't need any camera here, and we realized while doing this surgery that the aorta is very close. So we started doing mini AVR from this approach. And you see, this is a lady, this is a patient, and you see very well the aortic annulus, direct vision. We get very perpendicular to the valve, and we use a running suture, 6 running suture for the valve implantation. These allow us to implant larger valves, which I think is important for in case of valve-in-valve procedure one day. And this is the non-coronary sinus annulus. And again, this is the left coronary sinus annulus. We're ready to sit down the valve. You know, we appreciate that the post of the avulus valve are a little bit flexible, so we can use very small incision. So I think this is a very important feature for minimal invasive valve surgery. This is the view of the valve that was, and this is the final result. Cosmetically speaking, this is, I think, a very elegant approach. You don't see any incision. You have to ask the patient to lift up the right arm to see the incision. And we are appreciating more and more the Avalus features for the minimal invasive cardiac surgery. The order is streamlined. There is a very low valve profile that enables perfect visibility of the valve. The suturing is very generous, so we can use, if you want, automatic stitch devices. And I mentioned earlier, the flexible stent can be bended. So this is a very important when we use in very small incision. And this is a valve also that is conceived for valve-in-valve, thanks to the radiopacity of the frame, valve dimension and geometry. And of course, the leaflet are mounted interior and not exterior. And as I said before, we're not doing only reduced incision. We're using minimal invasive extracorporeal circulation system to reduce blood loss, increase the biocompatibility of the extracorporeal circulation. This is our circuit for MEAC in cardiac surgery. And this is our experience. We just published on European Journal of Cardiothoracic Surgery propensity score match study, MEAC versus extracorporeal circulation in mini AVR patients, and we had less bleeding, less transfusion, less atrial fibrillation. And again, when you have 0 point something mortality rate, transfusion, atrial fibrillation, bleeding becomes primary endpoints, and we're targeting these measures of outcome to be to get improved. Ultrafast track anesthesia. This is what happens. This was a mini thoracotomy AVR, 81 years old lady leaving DOR. The operation is just finished. She's going to the ICU, extubated. Ultrafast track anesthesia provides many advantages and really allow us to be, in general, less invasive. This is the first one. After the operation, we go to the family and we can give information in a different way. We're not saying anymore the operation is done. It was minimal invasive, but you have to wait because the patient is sleeping. We don't know about respiratory outcome. We don't know about neurological outcome. Please come tonight, this evening, or tomorrow to know more about that. We can say the patient is, the operation is finished. The patient is extubated, neurologically intact. Please go in half an hour downstairs to the ICU and be close to your to the patient. So the burden of surgery is dramatically decreased. This means being minimal invasive as much as doing small incision. And you see the patient extubated in the middle, working with the physiotherapist and the daughter, which is just close to the patient. The perception of surgery is dramatically different, is dramatically reduced. And this is the lady, 4 hours after the end of surgery, which is sitting with legs out of the bed, of course extubated, working with the physical therapist. So this is a 360-degree approach where surgeon, perfusionist, anesthesiologist, physical therapist, and even family members becomes, all part of the heart team. They're all working together in one direction, and that is minimal invasive. And I can say that this kind of approach is also, building our reputation. We're not just, this is not just a surgeon that is working minimal invasive, but this is a team that is in all the components, the anesthesiologists, perfusionists, nurses, families, they are all concerned to decrease the trauma, the invasiveness of the operation. And these are our numbers. We're running at the speed of about 100 TAVR per year. We've done 166. This is cardiac surgery doing TAVR, and you see our results are showing that we can be safe and effective while doing TAVR, even in our learning curve period. And this is our minimal invasive AVR experience over the last 3 years, and you see that results are very encouraging. So I don't know what our minimal invasive AVR is going to be in the next 10 years, but I think that mix should be standard of care, and to do that, it should be simple and easy to reproduce. I strongly believe that, and I think that mix should go together with catheter-based intervention. I think that minimally invasive cardiac surgery should go beyond reduced incisions. We can do more. We can use latest valve and CPB technologies We don't have to be lazy. I'm particularly thinking about perfusion, minimal invasive perfusion. If you get some advantages for that, I think we have to use that. And I think we should promote multidisciplinary teamwork. Surgeon, anesthesiologists, perfusionists, nurses, physiotherapists, and families should all work to reduce the invasiveness of our operation. So while we continue to generate, get concerned and generate excellent short and long-term outcomes, I think we should also get concerned about improving patients and families' comforts, quality of life, and satisfaction. Thank you very much for your attention.
Okay, Marco, thank you so much for this presentation. I fully agree that minimally invasive is the way to go in surgery in all cases where it is possible and makes sense. So I would like to ask you, how can we achieve to increase the rates of minimally invasive procedures in cardiac surgery? I think in Germany, the rate for mini AVR is around 50%. So how can we achieve higher rates? How can we train surgeons? And which are the patients who should not undergo mini AVR?
Yeah, thank you, Sabine, for your question. Yeah, the penetration rate of mini AVR is still too low. What we're doing, as I mentioned earlier in my presentation, we're trying to keep surgery simple. You know, when you look at line of research for mini AVR, you see there is an increasing complexity. There is the idea that endoscopic is less invasive than mini thoracotomy, that rib sparing is better than mini sternotomy. While I'm not convinced about that, I think that surgery should remain simple, easy. We're doing the, the mini thoracotomy, just deconnecting the rib in the way I showed in the video. We having at the moment 90% of all valves done minimally invasive. So I think that is feasible. Training is an important part of it, but when you get minimally invasive AVR standard of care, the younger surgeon they will start from the beginning with the mini AVR. That will be natural to them, and it will be natural for them to learn it in that way. So I think easy, simple, reproducible. You can do mini sternotomy, you can do mini thoracotomy, but that's the way to go. The second question was, so what patients for full sternotomy? I think full sternotomy goes, at least in our experience here, to the complex cases. So the endocarditis with the large wide abscess, fistula, complex redo, of course, combined valve procedures, but I think only those.
Okay, thank you.
Thank you, Sabine.
Thank you, Marco. I think it's my turn now to ask Professor Bleiziffer Sabine, our second speaker, to talk about expanding options for bicuspid aortic stenosis patients and challenges for TAVR, but also SAVR. Sabine, we'd be happy to listen to you.
Thank you. Dear Marco, dear Thomas, dear ladies and gentlemen, I would like to share with you my slides about options for bicuspid aortic valve stenosis patients. So the usual normal aortic valve anatomy is a tricuspid valve, which has this appearing and which looks like this if it is stenosed. 1 to 2% of the population do exhibit a bicuspid valve. That means there are only 2 cusps there with some fused cusps, and when the valve is stenosed, it may look like this. There is a classification because there is a wide range of appearance of this valve, and the classification is according to the number of raphes. So if there is no raphe, it is also called the true bicuspid valve because you only have 2 cusps in this valve. We talk about the type 0 bicuspid aortic valve. It is about 10 to 20% of all bicuspid valves. The most common type is the type 1 bicuspid valve, where 2 leaflets or 2 cusps are fused. In most patients, the left and right cusp. So this is the most common type of bicuspid valve. There are also type 2 bicuspid valves with 2 raphes, and this is also called the unicuspid valves. I have said that we have about 1 to 2% of the population with bicuspid valves. When we look to a population that undergoes aortic valve surgery, this is clearly much higher. In the patients between 50 and 80 years old, it is more than 50% of the patients who have bicuspid aortic valve. When we look on patients who undergo transcatheter aortic valve implantation, TAVI, we see much lower rates of bicuspid valves in these patients. This is on the one hand because those patients are usually elderly patients in which we see less frequently bicuspid valves, but it is also because bicuspid valves used to be a contraindication for TAVI. Bicuspid valves were excluded for all studies. That means we don't have so much data. We for sure have no randomized data about bicuspid valves. And the current guidelines we have say that bicuspid valve morphology is somewhat a relative contraindication for TAVI, and those patients should more frequently undergo surgery in SAVR. So why is or used TAVI to be a contraindication in a bicuspid valve anatomy? It is because we put a valve into the native annulus, into the native calcium. We do not remove the calcium, and the bicuspid valves have a narrow longitudinal and not a triangular opening like a tricuspid valve. The calcium distribution is often asymmetric, and there is often a lot of calcium, so it is easy to understand that it is quite hard to put inside this narrow longitudinal opening around prosthesis. And that leads to often non-circular expansion, which then leads to paravalvular leakages or a higher risk for paravalvular leakage. If you see this CT with a TAVI in place, you can acknowledge the non-circular expansion of this valve. When we think about surgery, this is, does not make such a big difference if we see a bicuspid or a tricuspid valve. We do resect all of the calcium and we implant around, in most cases, a stented bioprosthesis or a stented prosthesis. So the difference between having a bicuspid or tricuspid valve is not so big when we do surgery. I like very much this photo, which I took from a patient, which was, I think, the most rigid aortic valve I have ever resected. It was really like a stone. There were not any mobile parts of this valve. It is a unicuspid valve, I would say, a type 2 bicuspid valve. I resected it on block just with a scalpel and took it out in this one piece. So, and this is also a photo I would like very much to show to the cardiologists to demonstrate that TAVI has some limitations. Another issue is that bicuspid valve anatomy is often large. So there are a lot of bicuspid valves with a very large annulus size, and beyond a certain annulus size, there is no TAVI option because the TAVI sizes are limited to a certain size. We don't have this limitation for surgery. We always can implant a valve, and we can even do downsizing if the annulus is very large. Another thing to mention is maybe that if we do surgery, we also can implant a mechanical valve and offer the patient a very durable result, which is no option in TAVI because they are all biological valves. The next is the aorta. It is known that patients with a bicuspid aortic valve often have concomitant aortic pathology. This is a study demonstrating that where patients with or people with bicuspid aortic valves were followed up for many years, and it was seen that during lifetime, 1/4 of the patient developed an aortic aneurysm, and about the same percentage of patients underwent aortic surgery. So we cannot do aortic treatment during TAVI, so this is also something which differs surgery versus TAVI. So why is TAVI so difficult in the bicuspid anatomy? Also the sizing, which we have to do by CT and in advance before the procedure, because we cannot size like surgery, is to define the annulus and to measure the annulus. The annulus is usually defined by the 3 hinge points of the cusps in the CT. These 3 hinge points define the annular plane. If we have only 2 points, it is much more difficult to define a plane, because there can be erroneous measurement. If you see that, you can see the correct annular plane is much smaller than if we do an error and measure not the correct plane, and there we always have an overestimation of the annular size and area. There was a lot of discussion about how to size bicuspid valves, and there was also the idea to measure the intercommissural distance instead of the annulus, and there were some publications about this now, and they came to the conclusion that the annular sizing should be considered the standard and not the intercommissural distance sizing. This was one publication from Dr. Kim, and another one also published recently by Dr. Cheche, and he also came to the conclusion that we should do annular-based sizing, which means some simplification, because it is much easier to size the annulus, like always, also like in the tricuspid valve, than to do this intercommissural distance, which can be taken also into account in difficult cases or in borderline cases. I would like to show you some outcome data of patients with TAVI and bicuspid aortic valves. This is data from a very large registry of almost 100,000 TAVI patients. 2,691 bicuspid aortic stenosis patients were identified and matched to the same number of tricuspid aortic patients. And the major results are that mortality is the same in the matched population, but there are some issues with the bicuspid valves. First, the 30-day stroke rate was significantly higher in bicuspid patients who underwent TAVI. The risk of procedural complications requiring surgery was significantly higher. Hemodynamics were the same, and there were no significant differences in leak rates in paravalvular leakages. Another sub-analysis of this STS-ACC-TVT registry, investigating only the Evolut R valve, self-expanding, resheathable and retrievable valve, demonstrated comparable results for aortic paravalvular leakages, and also no difference in the stroke rates. Looking at another valve, the Lotus valve, which is considered to be very eligible for bicuspid aortic valve patients because it has a very good sealing, demonstrates no significant difference in paravalvular leakages, but somewhat a trend for more leakages in the bicuspid aortic valve patients. This is a sub-analysis from a large registry with this Lotus valve. And in this registry, the stroke rates were also the same in bicuspid and tricuspid anatomies. Another thing that has come to our attention during the last years is that with newer generation valves, the results are improving. So this is again a sub-analysis from the STS registry demonstrating 3 generations from the same valve, that the results improved over time from generation to generation. The latest generation is the Evolut Pro valve, which has an additional sealing skirt at the bottom and has the best leakage data in bicuspid aortic valve patients. There is also multi-center data demonstrating the same thing, that new generation devices have better results. That also shows that we are improving our outcomes with increasing experience, I think. So this multi-center study demonstrated significantly better data for paravalvular leakages with newer generation devices, and significantly better device success with current generation TAVI valves. This all has led to CE mark approval of the Evolut TAVI platform in June this year for bicuspid aortic valve stenosis patients at intermediate, high, or extreme risk, so not for the low risk patient population. And why this valve may be eligible or is very eligible for a bicuspid anatomy can be also demonstrated with this video I already showed you. You see at the level, sorry, I would like to show it very slowly. At the level of the annulus, you can see this very non-circular expansion, but this also means that the valve conforms to the anatomy, and that prevents paravalvular leakages. When we go higher to the annular intercommissural level and then above that, it now gets somewhat oval, not really round, but this is the level where the valve function happens, and this makes us believe that the valve function is not impaired with this non-circular expansion at the annular level, and this would be something we would consider for long-term durability. So if valve function is not impaired, which we don't think at this level where it is almost round, we should not expect durability issues for this valve. The Evolute platform also has the characteristics of resheathability and retrievability, which increases safety, and also in difficult anatomies where placement might be hard or where it is hard to define the annular plane. In the bicuspid valves, you can reposition if this is not achieved at the first attempt in a perfect way. The valve is self-expandable, which reduces the risk of annular rupture in these patients who often have very high calcium burden. So finally, I would like to share with you two recent cases of our clinic. We just last week had a 60-year-old female patient, which should have cardiac surgery for her aortic valve stenosis. She had typical symptoms. She has also had a coronary artery disease, but with no indication for intervention now. But she had a severe COPD and lung emphysema. And there was a pneumologist statement telling us that her risk for general anesthesia is very high and for intubation. So we considered if we can also do TAVI in this patient. And the first we did was to perform a CT and evaluate her anatomy. Not surprisingly, this lady had a bicuspid aortic valve with a fused right and left coronary cusp. But the calcium amount was not too much. It was very asymmetrical, only in this corner. But the total amount of calcium was not too much. And together with a good peripheral access, which she had, we decided to do TAVI without general anesthesia, of course, only with conscious sedation. And this was the procedure. We implanted an Evolute R 29mm prosthesis. You see here the complete deployment of the prosthesis. And you also see there is incomplete deployment. There is a very sharp waist here. And this is very often the case in bicuspid anatomies because, of course, we have not a triangular or round opening. We have this non-circular, very narrow opening. So we decided to do a balloon valvuloplasty and to open the valve. It is now completely deployed. And the result was how we expected, with only minimal leakage in the end. So this is what we can expect also in bicuspid aortic valve anatomy. Our next patient was a little more difficult. This was a 78-year-old patient, and she was so frail. She was 43 kilograms. She was absolutely not mobile. She was bedridden. She had a history of cardiac decompensation with intubation. She was hospitalized for weeks. She had undergo pneumonia. And in this shape, she came to us after this weeks of hospitalization, and she was not even able to walk some steps in in her room. So I said, this is a patient who should undergo TAVI for sure. We did a CT and we saw a very crazy anatomy. It was a bicuspid aortic valve. She had a very low takeoff of the left main stem, but I considered this enough distance for a TAVI implantation. But the calcium distribution was very asymmetric. There was much calcium, and she also had this chunk of calcium in the LVOT. Her peripheral access was good. So I said, we can do TAVI. I would only do this with a self-expandable valve because of a risk for annular rupture. But this is a TAVI patient and we should do it. So you can see here a lot of calcium, some insufficiency, very low takeoff of the left main stem, but I think with enough space for a valve. Then we implanted the valve. You still see here enough space, or I considered this enough space for the left main stem. The valve was implanted. And again, like in the former case, we had incomplete expansion of this valve. Because of the bicuspid aortic valve anatomy, we see this quite frequently. You see incomplete expansion, and we decided to do a valvuloplasty. You see a complete expansion of the valve now. Balloon was very effective, and instantaneously after this maneuver, the pressure dropped, and we had to resuscitate the patient. After we stabilized her a little bit, we saw this. So the left main stem was occluded by some calcium, we thought. So now the heart team came into action. We put the patient on pump in the groin. We put in cannulas. This took us some minutes. And then we tried to reopen the left main stem interventionally. So the cardiologist did some attempts and told me it's impossible. He cannot reopen the left main stem. And so we decided to do conversion to surgery. And what we saw was really a piece of calcium in the left main stem like a cork. So this was really a unique anatomy. And we had not foreseen that this will really happen like this. Surprisingly, this patient did very well after the surgery. She took some days on intensive care unit, and after that she improved quite quickly, and she was able to leave the clinic. So although I had not expected this to be a good surgical patient, she did quite well, and we were happy that the heart team took all decisions like we did, and that we could save the patient's life in this case. So I would like to summarize now. The bicuspid aortic valve anatomy remains more challenging for TAVI than for SAVR, because for SAVR it does not make such a big difference if we treat a bicuspid aortic valve. The heart team has the importance to take the correct decisions in these patients. And what we saw during the last year now, that with new generation devices and with increased expertise, we have improved our TAVI results in bicuspid patients, and there is even one valve approved for this anatomy now. But we still need more data to better treat these patients. We have to compare different platforms. We have to compare to surgery. There is no randomized trial with bicuspid patients. And of course, we have to watch long-term results, because in the end, we don't know if this non-circular expansion does impact our durability of these valves. Thank you very much. I look forward to some questions and discussions.
Sabine, thank you very much for your excellent overview on bicuspid aortic valve TAVR treatment. I think there are a lot of questions that could rise from your presentation. I would like to ask Marco first to give us his thoughts and to ask you some questions about this excellent presentation. Marco?
Yes, Sabine, I really enjoyed your presentation, in particular the last case, highlighting once more how important is their team and how much is important to have a cardiac surgeon in the hospital and in the hybrid room as well. That patient is alive thanks to cardiac surgery. This should not be, put aside somewhere. I have one question to you. You show some data suggesting an increased risk of brain complication, brain embolic shower due to the increased content of calcium in bicuspid compared to tricuspid valve. Are you, for that, using catheter-based neuroprotection systems, or are you protecting your patient? Do you think this is the way to go? And last, I think we have to recall that TAVR is indicated intermediate high risk patient at the moment. Do you think in the future lower risk younger patient will be done with TAVR as well?
I think embolic protection does make sense. We do that in all younger patients in my clinic and in all patients where we think stroke risk is increased. So not in all bicuspids, but in those bicuspids with a high calcium burden. But maybe this is a good point, and maybe we should think about it if we just should do it also in all bicuspid anatomies. And the next question, to go to low risk patients, I think we really should do some, we need much more data for this, especially some randomized data versus surgery. We don't have any data on bicuspid anatomy, surgery versus TAVI. This is really missing, and this is something we need before we should move to lower risk patients.
Sabine, I have also a question with this regard for you. So recently Medtronic was granted a CE mark for bicuspid indication. It's the only one today who has a CE mark for TAVI in low risk in bicuspid patients. However, there are, from your presentation, I mean, we could tell that there are many variations in the interpretation of bicuspid. And it seems that we are over-reporting sometimes the bicuspid rate in TAVR patients in comparison to what we observe in surgery in elderly patients, which could mislead to these very nice results we observed that had Medtronic or allowed Medtronic to get granted for bicuspid. So do you still think, now that we have many registries, we have this CE mark, that a randomized controlled trial is needed? And if yes, how do you select the patients who are, or how do you interpret the results? Because they have the type 0, type 1, and in type 1 you have A and B, and so on. How to interpret all these results in our practice?
So I still think we need a randomized trial, TAVI versus surgery in bicuspid patients, to go for lower risk and to support the CE mark approval. We also have to compare different TAVI platforms with trials, maybe, because I think maybe one TAVI valve is better suited in special anatomies than the other one. And on the other hand, so most bicuspid valves are type 0 with left-right fusion, so the variations are not so big in the type of the bicuspid valve. The variation in the calcium distribution and everything is very huge. But if we do a randomized trial with enough size of patients, this should be matched enough.
So I think to shorten your presentation, I would say that bicuspid could be a safe and effective indication with the Evolute R. However, we have to be very cautious with the interpretation of the results and also how to do this. We have seen a complication where, although the screening of the patient would tell us that this should be a straightforward case, and also from what Marco have been mentioning, a hot team setting, especially in this case, is very, very important before generalizing the indication of bicuspid valve. So I think we can move on to the third presentation if you allow me, or if you don't have any other questions. I think it's my pleasure and honor to conclude this session hosted by a sponsored session from Medtronic. And I would like to make my talk a kind of a summary of what Marco alluded to, but also some of the limitations of TAVI expansion today that Sabine was brilliantly presenting. So I've been asked to treat the right choice for low-risk aortic stenosis patient, TAVR or SAVR. And I think if you put this in the confine of a heart team decision, it looks easy, but it's not that easy. So let me share this with you. They are my conflicts of interest. I mean, there is definitely a game changer now, which is the TAVI. I think it makes no surprise to anyone. Even the most reluctant surgeon are now accepting the idea that TAVI is here to stay, and TAVI is becoming the gold standard for aortic valve replacement. However, there are some limitations for this that we will be discussing together. So it's also very important to know where we come from. So TAVI in expansion of indications are not a surprise. We started validating the indication in extreme high-risk patients, and then we moved on to high-risk patients, and then intermediate-risk patients, and then low-risk patients. In the whole history of medicine, and especially in surgery, we have never had such number of studies, and especially randomized controlled studies, trying to assess the safety, the feasibility, the efficacy of a treatment like TAVI, and like the way we did it to treat aortic valve stenosis. And I think whatever we say, we can look at the glass full empty or full half full. But I think it's very important to be analyzing this very carefully and to accept that we have been accumulating a consistent number of data which prove that TAVR is a very good indication and is the gold standard today for aortic valve stenosis treatment, and the evolution of the guidelines is going into this direction. There will be some changes in the coming guidelines. So of course, to focus on the low-risk patients, we all know that Partner 3 showed the superiority of TAVR versus SAVR, and also did evolute our low-risk trial. And if we would like to combine and make a mix of these two different devices that were treating the same problem, it's easy to show that both studies, either isolated separately or combined, were showing that TAVR was superior to SAVR, and that the results were favoring TAVR versus SAVR in terms of hard endpoints, mainly death or disabling stroke. So I think in terms of safety in low-risk patients, I think there is nothing to discuss. And you can see it here on this slide that there was a constant evolution towards reduction of major endpoints complication in favoring SAVR versus TAVR, TAVR versus TAVR, sorry for this, throughout all the studies that we have been doing at least 10 years ago till now. This is a very important slide. So this is extracted from a meta-analysis to which we participated, and it was only based on prospective but also randomized controlled trials. So we tried, as you can see it here, in the controlled randomized controlled trials, just to focus on well-conducted trials. And you can see it easily that all these studies were in favor of TAVR versus SAVR, again, in selected patients. We have to be always careful on the way we interpret the results. The lecture, the reading of a result is very important to keep it into this perspective. So we know that now Evolute R has an indication in low-risk patients. But I mean, as a surgeon, I would say, who masters also TAVI indications, I can share some of the questions that rise from some other colleagues. These randomized controlled trials and the latest meta-analysis that I've been sharing with you, there are some doubts, limitations, and concerns that remain, rising from a surgical community, and which are understandable and reasonable and important to address. The limitations are age. Age means which is related to durability. The screening, which patient is better for surgery and which one is better for TAVR. What would you do in terms of dealing with concomitant procedures. Sabine treated the case of bicuspid, and of course there is a big question mark around HALT, which is valve thrombosis, which is apparently frequent following TAVR. I think the first point is very important. There should not be a mix or confusion between low risk and young patients. So the randomized controlled trials I've been alluding to showed that TAVR is superior to SAVR in low risk patients, and it didn't show it in younger patients. Only 1.3% of the patients were younger than 60 years old in the Evolute low risk trial, where only 7% of patients were less than 65 years old in partner 3. So both studies showed a superiority of TAVR versus SAVR in elderly patients. And this is very important, and there is no way ethically or clinically to go beyond this point. We validated the indication in low risk older patients and not in younger patients. This is very important. So the problem we are facing today is what to do if you have a patient who have aortic stenosis who is eligible for TAVR but also eligible for TAVR. And I think with the accumulated experience we have today, we know very well which patient is better for TAVR and what I call optimal TAVR indication. And so the questions are the following. Would TAVR be predictable? What is the predictability? Which patient will not fall into the box of TAVR-related complications? But also, as a heart team, we have to ask the question, which patients will not encounter complications that we have after surgery? And you know, again, these two results extracted from Evolute low-risk trial, but also for partner, it shows clearly that, for example, this is very important number to keep in mind, that in the screening process in these studies, 34% of the patients in the balloon expandable trial, which is partner 3, were deemed inappropriate for TAVR. So we have purified the selection and the population of patients that we have been treating with TAVR. And with Evolute R, it was much more reasonable, but still 14% of the patients who did not enter the criteria to be eligible for Evolute R low risk trial. So again, this indication was validated, but probably not in all patients, and we have to keep this in mind. The question is to know why. I think the patients were eliminated wherever we knew that there will be a risk of, for example, paravalvular leak. And paravalvular leak is less frequent now, but it still has a major impact. And if you are treating low-risk patients and eventually younger patients, you have to keep in mind, it's not only about how we measure the leak, it's the impact on the leak in a patient who have expectancy of life, which is for a couple of years. Because we know that impact of paravalvular leak on LV remodeling showed by Notion trial is an important issue, and that we have to be very patient and careful about the way we interpret this. Look at these slides. The last one shows clearly that the changes in the end-diastolic volumes related to paravalvular leak could have an impact on the durability and the results following TAVR. And I think this is a very important point that we don't discuss much. Pacemaker, okay. I would say if you have an elderly patient in whom you put a pacemaker, it could be acceptable, although we should not make it a normal or accepted feature. However, if you have a younger patient, I think it's not the best way to practice medicine today or TAVR if you wanna select the patient and offer the best services, I would say. So because impact of pacemaker on survival was shown extensively in all the trials that we know. Pacemaker implant is not the only thing, and left bundle branch block showed to be an important issue. It has been shown to be much more frequent after a balloon expandable valve than with the self-expandable valve like the Evolute. So I think this important of conduction abnormalities generated by TAVR is an important issue that we have to tackle. And there are some efforts that should be done in this direction. And we didn't win the battle yet, but we have a lot of ideas, and there are some routes that we could follow in order to show this. And I strongly believe that we can do much better, and that we should change our practice. Many centers still implant like we used to do it 10 years ago. And I think that cusp overlap technique is not enough. We should add something else. For example, the measurement of membranous septum, because the control of the valve will not be enough alone. The mismatch is a very important issue. So the mismatch, it's a surgical idea. It's not a hemodynamic idea generated by the cardiologist. Long time ago, a very serious study showed clearly that there is a negative impact of pacemaker permanent prosthesis patient mismatch on outcomes in terms of mortality, and you can see it here. And we have generated different levels of PPM, and we showed clearly that the more severe is the PPM, the mismatch, the more the negative impact we had on patients' outcomes. And these old studies from surgical literature have been confirmed by others in the TAVR, following TAVR experience, and it showed clearly that this could lead to structural valve deterioration, but also hemodynamic valve deterioration. And of course, all these things have a negative impact on the patient themselves. This is a very important study, the CHOICE randomized clinical trial, which was achieved also very recently. And it shows clearly that if you look at the hemodynamics at 5 years, if you have high gradients, it have a negative impact in terms of structural valve deterioration. And of course, this hemodynamic impact favors self-expandable valve, which is CoValve here in this study, over the SAPIEN. So the valve choice for a patient is very important. Also, if you take into account this consideration, this study has been corroborated also from by others. This is a slide taken from the VIVID registry, and if you have a high gradient following a valve-in-valve, when you use Edwards balloon expandable valve versus Medtronic self-expandable valves, it has definitely more risk of early deterioration than if you have had a higher gradients versus low gradients, as it was clearly shown here. I'm almost done. I think it's very important to be very patient and to interpret the results without any rush. If you consider the safety of the patient first. So I have 2 slides I want to share with you, which are extracted from PARTNER 2 trial follow-up at 5 years. And you can see clearly that the results are not as favorable as they used to be at 1 month and in 1 year. And it's what was in favor of surgery in the first days, it became in favor of what was in favor of TAVR in the first, at 1 month, at 1 year, it became favoring surgery during a late follow-up. And this is exactly the same thing if you look at the results from PARTNER 3, especially death or disabling stroke. So this positive superiority, I would say, of TAVR versus SAVR showed to be not as frequent as it was reported in the beginning. And if you look at the valve thrombosis risk, at 2 years, it definitely favors surgery over TAVR. So I think it's very important to keep in mind that we are expanding the indications, but this should not be an uncontrolled weapon. And if you put the patient in the middle of your practice, heart team is not the procedural team. It's definitely not to say, okay, I was number 1, the surgeon was number 2, or vice versa. I think a real heart team should put the patient in the middle of everything. And like Marco was saying at the beginning of his presentation, the minimally invasive practice should be a heart practice, a team practice. Moreover, I would say any kind of procedure today, the heart team should be in the middle of everything, but the patient comes first. We discuss all together and we choose which is the best indication keeping in mind that we need a fine patient selection. We should not accept it paravalvulate. We should not accept prosthesis patient mismatch, and we should not accept pacemaker. Of course, if this is avoidable, if you know in advance that the patient is at risk of developing any of these, this have to be discussed carefully. So again, to conclude, I would say there are strong evidence coming from TAVI in low-risk patients, as shown by Evolute low-risk trial. The indications have been expanded recently to bicuspid indications. Procedures are safe, they are easy, and they are reproducible. Durability demonstrated in only old low-risk patients and not in the younger ones. So you have to be very careful. Heart team is more than ever in low-risk patients and eventually younger patients mandatory. It's ethical and it's clinically needed. It helps the selection and the best or optimal indications. And I think we have to be careful and patient and continue to evaluate bicuspid indications, concomitant coronary disease presence, and also the need for combined procedures. And any action you may take, it should keep the doors open for another treatment in the future. Thank you very much.
Thomas, thank you very much for this overview. I think the most important message of your talk is that the low-risk patients we are talking about who do very well in TAVI in this randomized trials are a highly selected patient population, and that it is not the same as young patients. So I think this is very important and should be taken, and we have to have this in mind when we take decisions for the patient. To me, it is very interesting to see that the partner 2 long-term data have crossing curves. So the advantage the TAVI patients have during the first 1 to 3 years is gone after some years, and surgery and mortality data are increasing and are better. So how can we, with that in mind, how can we take the best decisions for the patients?
Yeah, so Sabine, thank you for your question. I mean, I would say if you stick to the results we have, not on the efficacy of safety of the procedure, and you stick to indications which are supported with some follow-up, which means up to 2 years. It's today, in my mind, if the patient is not an octogenarian, it's not ethically correct to go straight forward for a TAVI. Of course, this population could be sometimes at higher risk than expected because the risk is not captured alone by the risk scores calculation. And I think every patient should be considered different from the other and should be indicated, as I would say, à la carte. So yes, TAVI is easy. Yes, TAVI is straightforward. Yes, is simple. However, if you have a patient with a long expectancy of life, based on what you just have been mentioning with this crossing curves again after 5 years from partner 3, we have to be very careful in younger patients. So we still don't have enough data to go for younger patients.
Thomas, can I make a question? Yeah, I agree. The lower is the risk, and the more important the heart team gets, since SAVR and TAVR have very clear limitations. So patient selection becomes crucial for good results. But when we're talking about low-risk patient, do you have an age limit? When you start considering in low-risk patient TAVR?
I mean, listen, honestly, I think that it's too early for us to define any algorithm which will be the Holy Bible for all the patients. Let me give you an example, for example. I mean, you have a young lady who's 70 or 75 years old. Let's make it easy. You do a CT scan, which I think it should be in our routine practice. And you want to go for surgery. You want to do minimally invasive or whatever. And you see that she has a very small annulus. We know that PPM is not good for the patients. And you know, by putting, for example, 26 evolute R valve, you will achieve lower gradient and quick forward procedure. Do you think this lady is better or better eligible for surgery? I don't think so. And so I think the question is not really as easy as we consider it. For me today, if you ask me what would I do with a patient who's 78 years old, I would say who's in a good shape and who has a large anatomy and he could be easily operated on, I will put him on surgery. If he is a bit frail, if he doesn't have a big activity, if he has any concomitant disease, I will put him into TAVR. And in between, we have to be very careful and wait.
Yeah, I agree. I agree. What do you think, Sabine? Do you have an age limit?
No, we don't have an age, not a clear age limit. Above 75, we usually go for TAVI if there is no contraindication for TAVI. And below 75, it's always heart team decision. And below 70, it's always surgery. So instead of high risk. Except for high risk, I mean.
You know how TAVR favorable I am, but I mean, let's put it this way. You have a man of 75 years old in whom you could put a surgical valve doing a minimally invasive surgery, I would say. And you know, for example, based on partner 2 trial, in 5 years, this valve would degenerate. So you have to operate on him, or you would go for valve in valve. We don't have enough data supporting the TAVR in TAVR, I would say. What would you do? We know that the surgery after TAVR will not be always as easy as we imagine. I think at the EACTS meeting and also later in PCR London Valve, we'll be presenting on this explant registry. And we know that things are not always as easy as they are. So, I mean, studies alone are not enough because studies are not, are piloted by some considerations which are different from real life. But I think there should be some follow-up, and we should be very close from what the literature is showing us.
Exactly, and that's also why we encourage all our patients below 75 who are eligible for that to participate in the studies. So we participate in DEDICATE and the RIA trials, which are all randomized trials against surgery. I think these data are so important.
Absolutely. And
yeah,
on the other hand, also, Marco, I mean, you can talk about
yes.
it. I think surgeons should be very careful in putting everybody and pushing everybody into surgery. We know that surgery also can lead to some complications, and the best way to do it is to really be involved in the TAVR programs.
Yeah, I think as I tried to explain in my presentation, for us learning how to do TAVR was really helpful. So some patients that we would have certainly operated on, now we're shifting them to TAVR, of course, but also we would not treat TAVR with TAVR patients that would do very much better with surgery. For us, 75 first option remains surgery if the life expectation of this patient is reasonably long. And also because I think I'm a little bit concerned about the results in terms of mortality and morbidity that have been reported by the major trials. You know, we have mortality at 30 days and stroke rates of 0. Which is much, very distant from 1.82% that we read on the trials. So this is really disappointing for me as a surgeon. I don't know what you think about this, but.
I think this is a very important question. If you look at the mortality rate and the length of the operations that have been reported and the length of cardiopulmonary bypass reported and the length of the aortic cross-clamping that have been reporting following surgery, it has nothing to do with our practice. It's much more longer than what we have. But again, I think we have to be very careful. I mean, you work in a very big center, Marco, Sabine even bigger. And what our practice is not necessarily the picture of all the other centers. So I think also the experience of a center and the outcomes should also help and lead the indications. That's what I say. Studies are okay, but real life is completely different. But I agree with you. I mean, we have numbers which are much less than 1% and far away from what have been reported in these RCTs, which is good for us.
Can I make a question? Can I make a question to all of you, to both of you? So you are surgeons. We are all surgeons doing SAVR and TAVR, as far as I understand. So what is the role of an interventional cardiac surgeon in the heart team? What is your idea about that? Sabine.
So I think I really see this as an advantage that I know all procedures very well. So I think the judgment I can do for a patient is very unbiased.
Yeah, yes. I would add also that it makes you very equal to the interventional cardiologist. This is first. So you are equal in terms of, you know how to do it, you know how to manage it, but you are superior in terms of planning the case, because you know the anatomy, you have seen many other things. I mean, the case that Sabine was showing us, the second case who blocked the coronary artery. I mean, this is something as a surgeon that we can know, because if you have a bicuspid type 0, so both leaflets are equal in terms of death, I would say. So you can imagine that if the coronary ostia is just in the middle of the sinus, this can happen. And this is something as a surgeon that you can know, and this is much more an advantage over the cardiologist. In the same time, I think it's very secure to have an interventional cardiologist in your room. If this happens, you can quickly try to catheterize the coronary arteries. You can plug VSD. You can do many other interventional techniques and enlarge your practice. And this is the beauty of it. I think honestly, we should do everything possible to put together this hybrid team.
But I see that the surgeon, you know, is real. In the vast majority of cases, the position of the surgeon in the heart team is relevant in the meeting room, but a bit less in the hybrid room. So, what should we do to gain some balance in the hybrid room as well?
I think surgeons have to assume the fact they didn't really believe from the beginning in TAVR, and they didn't get a real interest in the TAVR. I mean, you are here, Sabine is here, and I'm here, and we have patients who are referred for us, and we drove them into the TAVI practice. I think today surgeons should stop operating on everybody and sit on the table and discuss some of their patients who are candidate eligible for TAVR and try to do them together. There's a lot of possibilities for discussion, and I think this is more possible now in low risk and younger patients, because these patients still come to you, and these patients still have to be validated by you, because if anything happens, the cardiologist alone cannot afford the responsibility. So the door is open, but I think this is the last one, and we have to negotiate it in this direction. And also, this is not the topic today, but for mitral and tricuspid, it's not too late. We are in the beginning of this new indication, and I think if we put all this together in this box of our team, I think we have enough material to sit around the table and discuss. But I agree with you, it's much easier in a meeting or behind the computer than in real life.
Maybe I can put together also my views on the heart team, because I think this the interdisciplinary heart team gets really the best out for the patient, because everybody has his view, another view and another knowledge in behind, the cardiologist and the cardiac surgeon, also an interventional cardiac surgeon who can do both procedures. And we learn from each other every day, also after many years of cooperation. And I think we should not say as surgeons we can do it alone, we don't need the cardiologist, but we should build our heart teams, and we should develop and let the heart team make an evolution over the years further, also for the new procedures, mitral and tricuspid.
So I would like to thank Sabine and Marco for this excellent session. It was a very stimulating content and the discussions that we had here. We try to be very realistic. We try to be very practical and pragmatic. Marco have made a clear and very enthusiastic overview about the evolution of aortic valve replacement surgical techniques. Sabine treated a very important topic, which is one of the latest domains that we are exploring in terms of TAVR indication, which have been recently granted by CE Mark for Evolute, our TAVR device. And I closed the session by a presentation on SAVR versus TAVR in low-risk patients. What the key point, the major key point that came out from this session was the importance of heart team in terms of evaluation, but also adoption of these techniques that we have been alluding to. We discussed together the importance of putting the patient safety and result first, and then combine all the efforts from cardiologists and cardiac surgeons in order to optimize the results. We also discussed thoroughly the way to interpret the data and available literature data. And we took a rendezvous for to follow up with these studies, and we encourage all our colleagues who will be listening to us to follow up with their patients and participate to the maximum studies that they are invited to. This is the best way to evaluate in the future the right indications. With this, I would like to thank again my colleagues, Sabine and Marco, but also Medtronic, who gave us this opportunity to share our practical and friendly overviews of these very important topics. Thank you very much, and see you